I'm a professor of medicine at Mayo Clinic, Arizona, and I focus on multiple myeloma from a clinical and research standpoint. And I'm also associate director of the BMT program and section head for the myeloma at Mayo Clinic in Arizona. The abstract that I presented is in relation to the use of a BCMA bispecific antibody, Etentamig, for patients who had a prior BCMA exposure, meaning these were triple class exposed patients who had a prior exposure to a BCMA-directed therapy, either a BCMA CAR T-cell therapy or a BCMA antibody drug conjugate. And there were very clear eligibility criteria on which patient could receive treatment as monotherapy on the clinical trial. I presented data from two arms of the phase 1b MONVISO study, Arm B, which focused on evaluating Etentamig without a step-up dose in triple class exposed and prior BCMA exposed myeloma patients. And I also presented safety data from Arm C, which evaluated Etentamig without outpatient treatment administration, implementing the use of a step-up dose. So the Arm B had about 41 patients who were included in the efficacy analysis. And 24 patients had a prior BCMA CAR T, 17 patients had a prior BCMA antibody drug conjugate before these patients received Etentamig as part of Arm B treatment. And so this was a heavily pre-treated patient population, median of 6 prior lines of therapy. Approximately half the patients had BCMA-directed therapy as their last line of therapy. And the data showed that the response rate to Etentamig in patients with a prior BCMA-directed therapy was approximately 46%. And it did not differ much when we broke the data down by prior ADC versus prior CAR T. The response rate was about similar, and most responses were very good partial response or deeper. But we did see that patients who received BCMA CAR T as the immediate previous line of therapy before being treated with Etentamig on Arm B, the response rate was 64%. Although this was a small group of, I think, 12 patients only, and all patients either had very good partial response or a deeper response. And we also saw that the duration of response was quite good in all patients who responded, was 13 months in patients who had a prior BCMA CAR T, whether they got it as an immediate previous line of therapy before getting Etentamig or at any point before being treated with Etentamig on Arm B. And the duration of response was not reached among patients who received a prior BCMA ADC. However, the progression-free survival, while it was 12.7 months in patients who received BCMA CAR T as the immediate prior line of therapy before receiving Etentamig, it was quite low among other patients receiving Etentamig at some point after a previous BCMA CAR T or ADC. It was approximately 3 months for the rest of the group of patients. So the only group that had a remarkably improved progression-free survival, it was patients who got BCMA CAR T as the immediate prior line. Yes, it's a small sample size to begin with, 41 patients in the efficacy analysis. And so when you do subgroup analysis based on prior BCMA modality, it becomes harder to, draw firm conclusions. Nonetheless, the progression-free survival is heavily affected by the responses. It seems to me that with the in general, bispecific antibodies, the responses tend to be binary. Either we see patients who have a response and it tends to be a deep response with more durability attached to it, or patients don't respond and they very quickly meet the endpoint of a progression-free survival um, in the analysis. So the response rate is not as significantly affected. It was approximately 50% for all patients, but the progression-free survival varied quite a bit, and so it ranged from 2.8 months to 3.4 months, based on whether patients got a prior BCMA CAR T or prior BCMA ADC. In a sense, it was on the lower end of um, the spectrum compared to patients who got prior BCMA CAR T immediately before receiving Etentamig, where it was, I think, 12.7 months.